Lübke from Germany. Dr. Andreas?
Yes. Hello. Can you hear
Hello.
me loud and clear?
Yes, yes, please.
Okay.
Yeah.
I will start to share my screen. There it is.
Could you please introduce yourself, Dr.
Yes,
Andreas?
of course. I will just. So yes. Well, my name is Andreas Lübke. I'm head of orthopedic pathology and vice head of cytopathology at the University Medical Center in Hamburg-Eppendorf in northern Germany. And I kindly thank Utilitarian Conferences for the opportunity to present this keynote lecture. And as a topic, I chose bone metastasis, a practical approach to differential diagnosis, because this is what I'm doing every day, first of all. Second, we will cover many fields of pathology, because as you know, any tumor can metastasize to the bone, and therefore we'll see a lot of different pathological disciplines. And one other thing is, when we are dealing with artificial intelligence, this might be a really challenging topic. So we go through it, and after that, you can decide whether this is easy or maybe challenging. So just a second. Yeah. So we start with the basic principles. First of all, bone metastases are more prevalent than primary bone tumors, about 25:1. And the most common primary sites are well known. It's the lung, the breast, the prostate, kidney, and the thyroid. And frequently affected bones are the spine, the skull, the ribs, the pelvis, humerus, and femur. So it can appear almost anywhere in the body, and it depends on the type of clinicians you are working with. For example, if you've got a well-working spine center, you got a lot of biopsies from the spine. Bone metastases are more frequent in elderly patients because, as we know, elderly patients frequently get cancer. And the bone is the third most frequent site of metastases after lung and liver. So if you are a hepatopathologist or a lung pathologist, you will truly see metastases like in the bone. So it doesn't matter whether it's the bone, the liver, or the lung. And usually the marrow space is affected. In the long bones, metastases frequently involve the metaphysis. But in the distal to the knee and in the tibia, you rarely find metastases. It's important to know that any malignant tumor can metastasize to the bone. So you should stay open-minded for any differential diagnosis. How do bone metastases become apparent? First of all, we got pain. We can have pathologic fracture. We might detect the metastases at a PET-CT, which is very sensitive, and also an incidential finding. So same as primary bone tumors. On radiology, there's a broad range of appearance, from lytic to sclerotic. Well, basically depending on the type of tumor. For example, renal cell carcinoma creates more lytic metastases, or thyroid carcinoma does the same. And prostate cancer, breast cancer, and neuroendocrine carcinomas are known to produce so-called osteoblastic metastases. That is true, but from my own experience, and especially on the microscopic level, you will see that any tumor can produce any kind of metastases. But those are some basic rules of thumb. The differential diagnosis includes primary bone tumors, which have to be differentiated from the metastases, of course, and then hematologic neoplasms, of which the plasmacytoma is most frequent. So it's a more philosophical question whether the plasmacytoma is a primary bone tumor, because the bone is the home of the bone marrow, and therefore you might classify the plasmacytoma as primary bone tumor, or you can just classify it as an hematological neoplasm. But today we won't talk about hematological neoplasms in the bone, because this is quite difficult and this is very complex, and it's very difficult to manage this in the time of 40 minutes. Another important issue can be epithelioid vascular tumors, especially due to the fact that those are positive for cytokeratin. So the general approach to bone metastases is to think of the patient's history and clinical context, because this gives you a lot of information what is in the differential diagnosis. And after that, you first of all, as usual, go to the conventional histomorphology. And those two facts combined, the clinical context and the conventional histomorphology, are the most important clues to your solution. And always keep in mind what is frequent is frequent. So you will find lung carcinoma, breast cancer, prostate cancer, kidney cancer, and thyroid cancer very frequently in bone metastases. Additional stains can be very useful, especially when your resources are limited. The most important stain for me in the bone metastasis is the Astra stain, because you find bright blue mucinous vacuoles, which speak for adenocarcinoma, if you do have an adenocarcinoma. The iron stain is very helpful in differentiating hemosiderin from other endogenous pigment. And what is also very useful are frequent sections of H&E slides, because sometimes the bone metastases can be created of a limited number of cells. So do more sections always. When I got a tumor suspicion and I do not see a tumor in the first slide, I always do at least one immunohistochemistry, basically one cytokeratin, and 2 to 4 additional slides. And if I see no tumor, I can truly say, well, this is negative for a tumor. Next thing is immunohistochemistry, the most important tool when we are dealing with metastases. And here are the 5 most frequent tumors that metastasize to the bone with the according markers. If we got a lung adenocarcinoma, it's very useful to test for TTF1 and nepsin. Well, nepsin can fall out if TTF1 is negative, because nepsin is downstream of TTF1. But never forget that some lung cancers, adenocarcinomas, can be TTF1 negative. The most reliable marker for the breast is the nuclear marker GATA3, followed by mammoglobin, which is very sensitive. And you can also add GCFP50. In the prostate, very sensitive and very specific markers are PSMA and the androgen receptor and NKX3.1. PSA frequently falls out and is not expressed anymore. PSAP can be quite sparse in some cases, and ERK is basically limited to the prostate carcinomas with temporary ERK aberration. The thyroid carcinoma is marked by TTF1 and thyroglobulin, and additionally of PEX8. So if you got a neoplasm which is positive for TTF1 and PEX8, this is very likely to be a metastasis of thyroid carcinoma. And the last frequent one, the renal cell carcinoma, stains nuclear for PAX8 and also the classical marker RCC. And the clear cell renal cell carcinoma is positive for carbonic anhydrase number 9, which is quite a specific marker in this particular question. A pitfall can be tumors with keratin-positivity other than carcinoma. And first of all epithelioid vascular neoplasms are positive or can be strongly positive for keratin. But if those cells are without any atypia and look vascular, it's not a real big problem. Then the osteosarcoma can make cytokeratin expression, usually not as strong as in carcinoma, but on small biopsies, it can be challenging. In the right location, for example, in the tibia, where metastases are not that frequent, an important differential diagnosis for cytokeratin epithelial elements is the adamantinoma. But you can have some aid with Chem 5.2 because this is negative in adamantinoma. And last but not least, malignant mesothelioma is always positive for keratins, especially pan-cytokeratins like AI, AE1, AE3. So if you got any suspicion of malignant mesothelioma, better check with some mesothelial markers like WT1 and calretin. So what is my practical panel for and cancer of unknown primary? Well, that's what I do quite frequently. It's this small panel, one special stain, the Astra, followed by cytokeratin, TTF1, PAX8, CK7, CK20, TDX2, and GATA3. That's for all. And for the women, I also add the estrogen receptor and the progesterone receptor. And in men, I include the androgen receptor and PSMA. So that's how I start when I would like to know where the metastasis comes from. So now we have worked out the theoretical basics. And now we do some exercise. I prepared 6 cases of very common bone metastases as a warm-up, and then we go into the real life, 12 cases from infrequent to challenging. So this is a little bit like rapid-fire pathology, but I think it's a good training and sometimes a good quiz to see whether you recognize something that might be of your own special pathology discipline. So the first case, a 52-year-old male. He's got a lesion in the thoracic vertebra, number 7. And the history tells us that there's a clinical suspicion of lung cancer. So now we take the first histological image. The low power image has a blue look. We go to higher magnification. The look is still blue. The nuclei are a little bit smudgy. And if we go to a higher magnification, you see that the chromatin is something like salt and pepper-like. You see some crowding and some molding, like here. The cytoplasm is basically scanned, but sometimes of intermediate size. And you see frequent mitoses and apoptosis, like here and here and here. So another image with lots of mitoses. So I give you 1 or 2 seconds just to make your thoughts. And then I will provide some immunohistochemistry. Of course, the salt and pepper chromatin, the smudgy appearance, and some nuclear molding, a high proliferation rate is a little bit suggestive of neuroendocrine differentiation. And we would like to see whether this is true. The cytokeratin is not very intense. I have to say that this might be alterated or even missing in some small cell carcinomas. And basically, we find a rim and dot-like pattern, which is quite well to be recognized here. Not very intense, I know. So, but if we go for neuroendocrine, we have to use an endocrine marker. So this is synaptophysin, and this is strongly positive. So it's an endocrine neoplasm. We add chromogranin with also reliable positivity. And you got another marker, the CD56, not very specific, but usually strongly positive in neuroendocrine differentiated tumors. The Ki67 is very high. So in summary, this fits well to a poorly differentiated neuroendocrine carcinoma of the lung. And follow-up presented a 7 centimeters measuring tumor in the right upper lobe of the lung. The next case is a 76-year-old man, again, suspicion of lung cancer, again with an osteolysis in the lumbar vertebra number 4. So this is the low power view. You see the bone, and you see that the bone marrow is replaced by a lesion here. we take a closer look. Again, some time to think on your own. And then I go to a higher magnification, and you see that this tumor forms glandular structures. So this is a gland, also a gland. Maybe those are some vacuoles, but it's difficult to interpret. The tumor cells are polymorphic and show some nuclear atypia. Some atypia is very strong. This is an atypical mitosis. Prominent nucleoli and high variation in size and shape of the cells. And of course, this is cytokeratin positive. And then we go to our special stains, the Astra stain, which highlights the intracytoplasmatic vacuole. So this is adenocarcinoma. And if we got suspicion of lung cancer, of course, we do TTF1. This is positive. And with this simple pattern, it's possible to make the diagnosis of adenocarcinoma with very simple methods. Of course, keep in mind that you might add 1 or 2 additional markers just to be safe. So this is metastasis of adenocarcinoma of the lung. The next case is a 74-year-old woman with suspicion of renal cancer. And she's got an osteolytic lesion in the pelvis. This is the low power view. Here is the bone. Here is the bone marrow. And this is the lesion. The higher magnification. Almost no tumor left, just the lesion. And then we go to the highest magnification, and you see that the nuclei are quite small, but with recognizable and noticeable nuclei. You got a clear cytoplasm, and you get some nested and trabecular architecture with a loose vessel pattern background. And of course, when we think of the possible differential diagnosis, renal cell carcinoma, especially renal cell carcinoma with this clear cell appearance, is highly likely. So what do we do to prove this diagnosis? Of course, cytokeratin, always useful. Then we go for PAX8, a very specific and reliable marker for renal cell carcinoma. Vimentin is a more classic marker, not very specific, but in the past used quite frequently, and of course, positive in renal cell carcinoma. I do not use the Vimentin in the routine panel, but sometimes for reasons of illustration, it works quite well. And the more new and more specific marker would be the carboanhydrase number 9, which we do see here with a very clean green membranous staining. So this all fits to a metastasis of clear cell renal cell carcinoma. Our fourth case, a 73-year-old man. He suffered from prostate cancer in 2012, and now he's got a fracture of the thoracic vertebra and is paraplegic. So when we go for the bone histology, of course, we think, well, first differential is prostate adenocarcinoma. Thus, this might fit to our histology. So this is the bone. And of course, we see some infiltrates. So, and the first question is, might this be prostate adenocarcinoma? So this is more glandular structures with a high level of atypia. It's not possible to recognize any single gland or structures like in the Gleason 3 pattern. It's more like fused glands and high nuclear atypia with some focal area of necrosis. And well, to be sure, to have carcinoma, we do keratin, which is positive. And the glandular appearance lets us think of adenocarcinoma. So what can we do to prove that this is a prostate cancer? We start with PSA. And as I said before, PSMA can be lost by the tumor, especially in advanced stages. And some patients progress even under the PSA surveillance. And if the tumor loses PSA, he goes beyond the screening, and then the tumor can grow and progress. And this might happen here. So we see the PSA staining is in single cells apparent, but most of the tumor cells lost it. Also, a marker that can be challenging to interpret is PSAP. It's basically on the apical side or one side of the tumor cells, but scattered cells are positive. Then we go now to the more specific and sensitive markers. PSMA is a very good marker, therefore it's included in the first panel. And you can see this is a very clean positivity for PSMA. And another very attractive feature for PSMA is that PSMA stains endothelia. So you got a beautiful internal positive control on your slides when you see those small capillaries. The next marker is very strong and very reliable and very specific. It's the androgen receptor, usually with a strong nuclear positivity and cytoplasmatic co-staining. And also very specific is NKX 3.1. Well, in our hands, it's a little bit cleaner than the androgen receptor, and again, highly reliable. So if we have this bunch of markers positive, the metastasis of prostatic adenocarcinoma is very clear. The next case is a 57-year-old man, and he's got an osteolysis in the rib. This is the low power view. You see that there's very few bone trabeculae, and basically this is all the lesion. We go to a higher magnification and see that this is very well vascularized, lots of vascular spaces. Now the highest magnification, just make your thoughts. Well, and then you see that those tumor cells are quite small. They have a dense chromatin, and they've got intranuclear inclusions, this brighter areas here. We do not really see grooves. The cytoplasm is quite indistinctive, it's quite clear, and you can imagine some follicular structures. So quite monomorphic, not very atypical tumor. So first of all, this proof, is it cancer? Is it epithelial? Yes, it is. So we go further on in our panel. There's a positivity for CK7. Of course, CK7 is positive in adenocarcinoma, but in many, many other carcinomas. So what I try to highlight is that CK7 is a very useful keratin, but it's no proof of an adenocarcinoma. Then we go to TTF1, and now we've got a quite distinctive selection. So this is likely to be adenocarcinoma of the lung or thyroid cancer. And to go for this, we can make another marker like PAX8. And if we got a nuclear PAX8 positivity along with a TTF1 positivity, it's basically the proof of thyroid cancer. And to go further on, we can do thyroglobulin. And if this is positive, the diagnosis is perfect. And what I did not tell you in advance, this patient had papillary thyroid carcinoma in 2014, had radioactive iodine treatment, and bone metastases metastases are known for a long time, and this osteolysis was a new one. And what I would like to add is that it's difficult to tell which histology the primary tumor was. Of course, this neoplasm has some features of papillary thyroid carcinoma, like the intranuclear inclusions, but of course they are not very specific for papillary thyroid carcinoma and metastasis. So it's very difficult to tell the primary histology, but what we can tell, this comes from the thyroid. So the last case in our warm-up, this is a woman, 92 years old. She had breast cancer in 2019 with liver metastases, and now she's got a spontaneous fracture of the femoral head. This is the bone. Now we go to a higher magnification. You see the bone, and this is the tumor. In the higher magnification, we see gland-like structures, sometimes a little bit nested architecture, epithelioid cells with an intermediate variation in shape and size. We can see visible nucleoli. So, and this is basically the description. What we can also do, we can do the astrostain, which is positive with intranuclear vacuoles. So this might be adenocarcinoma. It's positive for CK7. And in our panel, we have a nuclear staining for GATA3. So if we got adenocarcinoma that's positive for GATA3, it's highly likely to be breast cancer. We can add mammoglobin, which is very sensitive, but can be inhomogeneous. And same with GCDFP15, which also is quite reliable, but not always positive. And if we got a suspicion of breast cancer, we also do the hormone receptors. At the top level, we see the estrogen receptor, and on the bottom, the progesterone receptor, which is also positive. So this is a quite characteristic histological panel and immunohistochemical panel of a metastasis of breast cancer. So this is the warm-up, and now we go to the challenging cases. 12 cases. I try to go through this quite fast, so we see all the 12 cases. A 70-year-old man, he had prostate cancer and colon cancer, and now we got a lesion from the thoracic spine. This is the overview. You see here some woven bone of a fracture region. We see this, atypical glandular structures. And if you show this image to a gastroenteropathologist, I think he will have no worries, because this is the classic morphology of this entity. We see elongated atypical nuclei and gland-like structures with a quite characteristic architecture. And when we do our special stains, of course, it's positive for keratin, and we've got some mucin in the astrostain. More specific markers are CDX2 and CK20. And if you would like to add a fancy marker, you can use the ZB2. So now the pattern is completely finished, and this is the characteristic morphology of colorectal adenocarcinoma. So the final diagnosis is metastasis of colorectal adenocarcinoma, early visible even at the conventional histology. Here's a 80-year-old man. He's got infiltrates in the calvarium bone. Here we see the bone, and here we see quite dense infiltrates. I give you a higher magnification. And here you see nested and whorled tumor cells with psammoma bodies. There are 3 tumors that do make psammoma bodies. It's the thyroid cancer, it's the cancer of the ovary, and this is the third one that can produce psammoma bodies. And if we do a cytokeratin, it's negative. This is also quite characteristic for this tumor, because meningothelial tumors do not express keratin. So, and this is highly suspicious of meningioma because we've got nested and meningothelial-like appearance, and we got this psammoma body. What can we do to prove this? Of course, it's S100 negative, and it's a bone not very far from the meninges, so it's the calvarian bone. And if we go further on, we can do an EMA stain, which is positive. We can do a somatostatin receptor. We can also do E-cadherin, and meningiomas are also positive for the progesterone receptor. So the final diagnosis is meningioma of WHO grade 3, because we see a characteristic meningothelial architecture, no high-grade atypia, and no elevated mitosis rate. The next case is a 85-year-old female, and she's got painful osteolysis in the humerus. This is the low power view. And now I give you a high power view. And what you see a malignant epithelioid neoplasm with a high level of nuclear atypia and variation in shape and size. The chromatin is coarse. The nuclei are sometimes very prominent. And what you also see, you see a brown pigment. And if you do an iron stain, this is negative for iron. And this lesion is also negative for cytokeratin. So what can you do to go for further analysis? Of course, you got an endogenous pigment, you got an epithelioid tumor. So malignant melanoma is a very important differential diagnosis. To prove this, you can stain for S100, you can stain for SOC10, that should be nuclear positive. So the final diagnosis in this case is metastasis of malignant melanoma. The next case is a 42-year-old man, and he suffered from a thyroid tumor 6 months ago, and now he's got an osteolysis in the left femur. This is the tumor. This is the higher magnification. So, and this is the maximum image. You see it's an epithelioid neoplasm with mitosis. It's very well vascularized, has some slit-like spaces. It's clearly atypical. The chromatin is coarse. And it's cytokeratin positive. So you might go for carcinoma, but then your whole bunch of immunohistochemistries is negative, including the specific markers for thyroid, like TGF1 and PAX8. So this is the problem, and all others are negative. So we go back to the conventional histology. And if you got an epithelioid neoplasm that shows some aspects of basal formation and is well vascularized and you see a lot of erythrocytes, maybe in the cytoplasm very close to the nuclei, like here, of course you should check for a vascular differentiation. So, and we do this. This is ERK, a nuclear marker for a vascular differentiation. This is CD31, also strongly positive. So this is a vascular neoplasm. And this is high grade. This is malignant. So in summary, this is angiosarcoma. Possibly it's the metastasis of a primary thyroidal angiosarcoma, or maybe an anaplastic thyroid carcinoma with vascular differentiation. We also see the primary tumor, and it was exactly the same image, a malignant vascular tumor with those two possible origins. The next case is a 25-year-old man. He's got a retroperitoneal tumor with compression of the left urethra with piloting. This is the low power view. And this is the high power view. We see gland-like structures. So this is a highly malignant tumor with apoptosis, mitosis, and strong nuclear atypia. And it's cytokeratin positive. So we think of metastatic carcinoma. Unfortunately, all our markers are negative. So the possibility that this is, for example, urothelial carcinoma is quite low. So, but then we think about the age and location. It's a retroperitoneal tumor in a young man. So if you got this, always think of a germ cell tumor. One reliable marker for a germ cell origin is Sol4. You can even take OCT3/4, but Sol4 is the most reliable. And additional clinical information after talking with a doctor, he had a very small lesion in the left testicle. So, and this is a metastasis of testicular cancer here with the appearance of an embryonal carcinoma. It was also CD30 positive, and the patient was treated accordingly. The next case is a 76-year-old woman. She had a previous diagnosis of metastasized malignant mesothelioma and now an osteolysis in the lumbar vertebra. This is the low power magnification. And this is the high power. And we see that this is a basaloid neoplasm with solid architecture, some reminiscent glandular elements. And we see that there are two different kinds of cells, larger cells and smaller, more basaloid cells. So what might this be? Is this mesothelioma? So, might be. It is strongly positive for cytokeratin, but the other mesothelial markers were negative. Calretinin was negative and WT1 was negative. So we looked for the differential diagnosis of other basaloid tumors, and we found some positivity for S100 and SMA. So if you got cytokeratin, S100, and SMA positivity with a basaloid solid neoplasm, you might go for a MIP translocation, which was positive in this tumor. So this was the metastasis of an adenoid cystic carcinoma of the lung, previously mistaken as a malignant mesothelioma. The next case is a 78-year-old man with an osteolysis in the lumbar spine and a known hepatocellular carcinoma. We see dense infiltrates of a tumor that forms glandular and strand-like structures. And this might be well compatible with a hepatocellular carcinoma, as we have got prominent eosinophilic nucleoli, characteristic architecture, a quite broad cytoplasm, and a large variation in size and shape of the nuclei. To prove the hepatic origin, we can go for HepAR1, which was positive in this case. We can add glypican-3, but the most reliable thing we can do is an in situ hybridization for albumin, which is positive in about 50% of all hepatocellular carcinomas. So this albumin fish proves the metastasis of hepatocellular carcinoma. The next case is a 15-year-old boy, and he's got multiple osteolyses in the left lower extremity, tibia calcaneus, and lots of other bones. So this is the low power view. This is the higher power view, lots of reactive bone. So this is the lesion. It's more spindle cell with intermingled osteoblasts. And of course, this looks quite benign. And from the conventional histology, this also might be a non-ossifying fibroma. But if you do cytokeratin, it's positive. And if you see this architecture, this might be a clue for the nature of the lesion. as we know that vascular neoplasms are also positive for cytokeratin, we can do some vascular markers. And this is ERK, strongly positive on the nuclear level. And we've got CD31, which is also very positive. So this is a benign, or well, this is a benign but aggressive growing neoplasm. So this is epithelioid hemangioma of bone. One vascular tumor of the bone that is positive for cytokeratin. Case number 16, a 41-year-old woman. She's got an osteoblastic lesion in the right humerus. There we see dense infiltrates and reactive sclerotic bone. A quite monomorphic lesion, a little bit gland-like. And the nuclei are something like hyperchromatic with some salt and pepper appearance. So first of all, we check for cytokeratin, which is positive. So this is some epithelial tumor. And then we had a positivity for CDX2. And given this bland morphology and the positivity for CDX2 and the neuroendocrine appearance, we tested for neuroendocrine markers, and synaptophysin was positive. Usually it's very difficult to name the location of the primary tumor. But in this case, we extended our panel and we found some positivity for somatostatin receptor and also for islet-1. And therefore, we could make the conclusion of metastasis of pancreatic neuroendocrine tumor, G2. So the next case is a 71-year-old man who had prostate cancer, and now he had an osteolysis of his thoracic vertebra. So this is the low power view. This is the higher power view. And this does not look like a prostate cancer. This doesn't look more like a spindle and pleomorphic sarcoma. So let's see whether there is some positivity for cytokeratin. We had this. And so we went on to look the whole material. We found this, some glandular structures. And those glandular structures were very positive for cytokeratin. And then we went for prosthetic markers. So this is the androgen receptor, and we see positivity in the glandular structures and less intensive, but true in the spindle cell component. Then we added NKX 3.1. And interestingly, we had some co-expression of CK7, which is very unusual for prostate cancer, and also CK20, which might be. But in the end, this is a metastasis of a sarcomatoid carcinoma of the prostate, luckily with some reminiscent gland-like structures. Otherwise, this would be a very, very difficult diagnosis. So quickly, the last two cases. This is a 56-year-old man with known malignant pleural mesothelioma, suspicion of bone metastasis. This is it. And in the intermediate power view, you see an epithelioid tumor with large nuclei and a broad cytoplasm with a mesothelial appearance with a variation in size, but not so much in shape of the nuclei. Of course, this is cytokeratin positive, which can be a pitfall. But if you do additional markers like BRP4, this is negative. But keep in mind that malignant mesothelioma can be positive for BRP4 in about 20% of the cases. But what you can do, you can prove the mesothelial origin with WT1. You can add keratin, and so you come to quite a good conclusion to a metastasis of malignant mesothelioma. So I go to the last case. This is quite short. This is a woman, 48 years old, and she had a solitary fibrous tumor in the calf 2013. Now she's got multiple pathologic fractures in the spine and lung metastases. This is the image of a bone metastasis. This is the higher magnification. And if you go deeper into it, we see this characteristic patternless pattern. Today, it's not very en vogue to say patternless pattern, because if you say patternless pattern, everyone says, yeah, well, this is solitary fibrous tumor. But we've got one more thing, this HPC-like vessels, arborizing vessels that are a little bit dilated. So what we can do to prove this, we can make one immunohistochemistry, which is STAT6, that should be positive on the nuclear level. So this is the metastasis of a malignant solitary fibrous tumor with a delay of about 7 years, which is not very uncharacteristic for solitary fibrous tumor. So the take-home message is, bone metastases, as I said before, are more prevalent than primary bone tumors. The most common primary sites are lung, breast, prostate, kidney, and thyroid. Any bone can be affected, and bone metastases are more frequent in elderly patients. It's very important to know the patient's history. About half of the cases could be solved with the patient's history in the conventional histology. The immunohistochemistry was only to prove this diagnosis. So patient's history, clinical context, and conventional histomorphology on H&E are most important. Any malignant tumor can metastasize to the bone, and please stay open-minded for any differential diagnosis. Now the acknowledgements, well, I would like to thank Dr. David Doom, who's my frozen section backup, because unfortunately I'm on frozen section this week. Thanks to Doris Höfelmeier, she's my orthopedic pathology backup, and she takes some cases from me that the pulse don't kill me today. And thanks to Dr. Maximilian Larratz and Niklas Blessin, who gave me technical support in introducing me into the scanning facilities, because all the images I made have been made with a scanning facility. Well, and now it's up to you to see whether artificial intelligence will solve all these 18 cases. If artificial intelligence solves all these 18 cases, I will retire at once. So, and with this in mind, I thank you for your attention, and I'm happy to answer questions. Thank you.
Thank you so much, Dr. Andreas, for being with us again and for presenting such a fabulous practical topic on bone metastases. Personally, I really enjoyed from your warm-up cases and also challenging ones. I would like to ask the audience if they have any questions. Please ask from Dr. Andreas. Any question? Okay, thank you, Dr. Andreas, for the presentation again.